Good afternoon, everybody. Thank you for hanging in there this long for this case controversy session. Anybody in the back, maybe yell out in the hallway to come on in. And as you come in, please use your cell phone to latch onto this. That's not the right phrase. What's the right way to say that, Katie?
Take a picture of that.
Oh, scan it. You don't take a picture, you scan
Well, you
it.
use your photo app and then you touch it.
If you take a picture, you can then click on the picture as well. There are multiple ways to.
Thank
Already
you,
some
Rod.
controversy
Thank you so
out
much.
there.
There are multiple ways.
That's true.
Well, for those of you who maybe this is the first time, John Waldhausen and I were trying to figure it out. We've done this for about 12 years now at ABSA, so this is a different type of session than the ones we've been in. There will be no p-values, and nobody's going to talk about molecules. We're going to talk about how you take care of your patient, and Todd Ponsky and Katie Russell and I are the facilitators really of a discussion that we hope you guys will join in on. That's what makes this fun and special. So we've got 5 microphones that are static, but more importantly, we have Katie and Todd running around with their own microphone to capture you and your opinion about things. So we've got at least an hour to talk about some cases. And again, these are going to be clinical practice pediatric surgery. This is stuff that most of us do all the time, so it's not something weird and strange. So with that in mind, Katie, take it away.
Thanks, Mac. All right, guys, so we're going to start out with this patient. So this patient seen on the screen, he's 6 months old and he's a boy, and he has been treated already for 7 days with Augmentin, and he presents with this abscess. He's in your ER. What are we going to do?
And you get called to come see it.
Yeah. So the questions here, guys, just antibiotics, aspirate it, I&D, or go to the OR for a drainage.
Hold on, Mac. I think there's it's okay.
It's fixed.
Who would put ECMO for?
ECMO?
Yeah. Okay.
All right, so people start voting, and we hope to start seeing your answers. There we go. I&D.
There's one choice missing, sits bath alone.
Okay, that's E. Okay. Anybody in the antibiotic alone group want to stand up and make your case? Come on now. There we go. Come on.
Ray. All right, you guys got to yell out because we won't see you with the mics.
Mark Downing, Kalamazoo, Michigan, and we used to I&D all of these until I think I learned that that increases the incidence of a rectocutaneous fistula, and now treat them all with warm compresses primarily. I thought antibiotics alone was closer. I didn't think about other. And we certainly don't take care of as many rectocutaneous fistulas anymore, and we've not had any deaths.
Anybody want to throw down against that? What?
Baby's in pain, so you want to pop it. Okay? So if you're going to pop it, how are you going to pop it? You have to vote, Kathy. Now, the needle idea may have been mine because I learned a long time ago that a mom, if you're seeing this kid in clinic and you've got this and you tell the mom, I'm going to stab it and drain it, she's very stressed. But if you say, I'm going to take a needle and aspirate it, but then you use that needle like it's an 11 blade, mom is much better with that. So are we voting? Quite a few needle users. Okay, we have a couple of others. Can somebody enlighten us about a better way to do this?
All right. Yes, keep going.
Right. Keep going, Katie.
All right, so you drained it. Now how many days antibiotics? Let's go ahead and vote on that.
I cannot wait to see this one.
So most people drained it. So let's see what people are doing.
Yes.
Is anyone from my group still here? Todd, you want to talk about this one?
Yeah. So we did a 5-year retrospective on all patients treated with no antibiotics, and there was one patient out of like 300 that came back ever with a recurrence. So you don't need antibiotics after drainage. The criteria was if it was greater than 5 centimeters or they had systemic findings, we gave antibiotics. But
Comment?
Are we going to go back to the discussion about draining it leads to increased fistula rates?
yeah, talk about that.
I don't know anything about that. I don't do that.
Yeah.
I drain them, but I want to know more about this potential increased fistula rate that I'm causing.
I'm actually intrigued because you said there's data, but if there is, it would be amazing to see that because
Mark?
Well, that's why we changed our practice, and I'm sorry, I don't have a encyclopedic memory. So I would say it was about 10 years ago, and I don't remember if it was at a conference or written someplace, but we certainly changed our practice, and we certainly have seen far fewer rectocutaneous fistulas that need to be taken care of later.
I could comment. I thought it was a 2008 or 9 paper written from MGH in Toronto that showed baby boys, well, gave the gender distribution, but showed that if you went to drainage that you had an increased risk of fistula afterwards, by Emily Christensen, Legay, and someone else. I forget the other authors, sorry.
No, you're right. It was one of those sequel of A Tale of Two Cities. They did a comparison of ECMO, CDH, between Boston and Toronto, and they did also big things like perianal abscess. And the lesson was the less you do, the better. But of course, even if you did get fistula and ano after it, Peña told us that we don't need to treat those either, and you don't need to do fistulotomies, which we used to do years ago, but now you let them heal on their own eventually. So that's why we don't do, and if you do something, because it gives in too much pain, you feel you got to do something, first of all, we start with just baths or compresses, as you do, and most of them will drain spontaneously, or at the most, nick it with the 18-gauge needle, as you suggested.
So, Mac, I guess a question for you is how can we follow up this session with things like this that need a little deeper dive? Because this is a big enough thing that's worth not dropping.
Well, this session is supposed to inspire research by those
but
people who
who's
feel
going to
like
take
we
point
have
on that? Raise your hand if you're going to
opinions.
take point on this project.
Hey, Todd, I can tell you that the Outcomes Committee
Yeah.
is going to do a project on this.
Okay.
This is one of next year's systematic reviews, if the Outcomes Committee decides to lower themselves to this level of review. But
Okay.
that's a plan.
All right, so
All right,
follow up
I am
next year.
going to go back to this antibiotic question. We've got 23% of us give 5 to 10 days, and we got Todd saying that's silly and wrong and don't give any. Anybody feel like we need to defend usually it's a football score, 7 days of antibiotics, 10 days of antibiotics, something like that. All right, let's keep going. Baby's now 9 months old, and guess what?
It came back. So now we're in clinic. The kid's here. It looks very similar. So what are we going to do? Are we going to do the same thing again, or are we going to do something else? Let's vote on it.
Whoa.
Others shot right up there.
All right, do we need a couple of people voting for other to tell us what that is? Come on now.
Just yell out. Don't even raise your hand because I won't see you. Who's an other that's brave?
Craig, are you another?
Yeah, you're an other. All right, we got another.
Yeah, I mean, we tell parents that these can come and go for months, if they're still happening till after the age of a year, or if they're causing like super uncomfortable bowel movements or, you know, just agonizing kind of symptoms, then we'll do something. But our practice is the same as Mark's, and I don't think I've done a fistulotomy in like 10 years. If they're getting frustrated, I'll offer it. I've had a couple of patients who have said, I'll take you up on it, and by the time we got to the OR, they changed their mind, and the kid was fine, and we never went.
So if we've aspirated the first time around, why not aspirate the second time around? It's the same natural history. That's what I would do.
How about, can we hear from someone who goes to the OR?
Sorry, miss, say that again?
From the OR team?
Oh,
All right, should we move on? So here's an open-ended question, guys. Is there ever an indication, or when is there an indication to do a fistulotomy?
Yeah, I think it's if it just keeps coming, you know, if it just keeps coming, and just like the gentleman said back there, if it's, you know, not going away and the family is frustrated.
So I have a question then. So Mac always teases me because I literally change half my practice every year after we do this. But this sounds like I've already going to make a couple changes. So question number one addressed was, now this possibility that we'll hear from the outcomes committee, hopefully, about this jumping to IND may not, I agree with the pain point, but for getting the pain issue, maybe you shouldn't be doing that. That's issue one. Would anyone here, based on just the crowdsourcing that just happened, change their practice one way or the other on that? Anybody? Not a single person. Okay. The second thing, it's funny because we don't necessarily have data here, but we have crowdsourcing, so we'll see how much that changes people's minds. The second one was antibiotics. There was quite a few people that give antibiotics after a successful IND with a ton of pus that comes out. Still give antibiotics. I did that a few years ago until we had the data of this. Would anyone change their practice on that? Based on what just 1, 2, 3, 4, 5, 6. So that worked. Okay, so far we got, gee, can we shut that door? Thanks. Okay. And then for this, I might change my practice here, what you guys are saying, because my answer for the fistulotomy / ceton is if it comes back once. I think I've been too aggressive maybe. A recurrence, I wait till the recurrence is over, and I go to the OR for an EUA if there's still a dimple there or something to see if there's a fistula to put in a ceton. Is that too aggressive? Okay. Yes. Okay. So how long do I wait? 3 times? When do you? 3 times. 3 times and you're out, Dave says. Forever? You guys? Really?
So if you,
Is there an age?
You're not
Does
doing
anybody have an
nothing.
age?
The treatment that you're recommending is not doing nothing. You're conducting active observation.
all right, we're gonna keep going. See, this is great. Sorry to push it along. Hang on. All right. You are asked to place a gastrostomy on a 3-month-old neurologically impaired infant in the NICU. He's tolerating nasojejunal feeds with occasional spitting up. Do you recommend an upper GI? Whoa.
That's a good
Classic.
controversy.
All right. I need someone to stand up and fight for each side just for the sake of our discussion. There we go.
So I actually wrote this up and published this, so my name is attached to this. But we did a study on upper GIs for G-tubes, and we found that it never helped us in our study. And it was, I forget how many patients, but there was like 300 patients in our study, and never did we find anything that helped us that we wouldn't have found at surgery.
You never found a malrotation or a hiatal hernia that was a big deal? Nothing. All right. How about somebody who likes getting them?
I think the question here is why are they being fed post-pyloric? They have a nasal jejunal tube. I would feed their stomach and see what happens,
So,
which is
well,
answer C.
a bunch of you are chomping on the bit about that. That's coming. Only question here is, do you get an upper GI or not? Then we're going to get to other ways of managing this kid. Okay.
Can we just say one thing? Never say never. He said never find anything. That's not true. Never say never. And one of my younger colleagues.
Actually, I didn't say we didn't find anything. We didn't find anything that we wouldn't have found in surgery already.
Okay, well,
So-
you do your lab gastrostomy and you find a congenital microgastria.
Yeah.
So, okay, what
I
do you
mean,
do
you're
now?
right, but the point
nice
is
to think
that
about it ahead
it's
of time.
extremely rare.
All right.
I
I think that tagging along, though, would you recommend pulling the NJ tube back in the stomach and test drive gastric feedings?
I was going to pipe up to say that, like, maybe 900 years ago or something, we did a study on the previous question too, and I think the incidence of any significant findings in ours was about 5% or less, so it was fairly useless to get an upper GI.
Thanks. Well, here's a consensus. This is as good as we do,
Next
I think.
question.
Yes.
Yeah, let's test drive the stomach. Then maybe we don't need an upper GI, or maybe we do now need an upper GI. Okay. Upper GI that you did get shows moderate gastroesophageal reflux. Do you recommend further workup, like with a pH probe? Does anybody remember those? All
Next.
right. Gone are the days. But at the end of the day, after you've test-driven some gastric feeds, the consensus is this kid has bad gastroesophageal reflux. He's throwing up half the stuff that he's getting in his stomach. And so now do you push for something called a fundoplication in a G-tube? Or are those days gone too? All right, we need the fundologist advocate. Who still likes doing that operation? You got to do it just right, though. Advocate for fundo? Casey, is that you? No? Craig, is that you?
No. I did my fellowship and did a fundo probably every day. I do maybe one every other year now.
Now, half of us are still recommending this thing that we don't do often anymore. Yes?
Yeah, so I do these much less often too, but for a neurologically challenged baby who's not going to protect his airway, I'd do a fundo.
In the old days at this, we would argue about how to do a fundo. Loose and floppy, how many stitches, max mob, min mob. I mean, it was funny, so now we don't do it. So. Here's a personal question. Yeah, me neither. All right, we're going to keep on trucking. Todd, you want, or Katie, why don't you do this one again?
All right, guys, we're going to do some ECMO questions. So this first patient, this is an infant, so let's say 6 months old-ish, 3 to 6 months old, who's got a viral illness, and the ICU's done everything they can, and they need to go on ECMO. No cardiac dysfunction, all respiratory. What is your preferred type of ECMO? VV, VA, or you don't have an ECMO center and need to transfer the kid? Anybody that said VA want to comment? All right, let's move on. So you did VV. What was your preferred technique? Do you do it percutaneous or open? Remember, this is a little kid.
I was wrong. I was surprised about that answer. I totally guessed wrong. I thought most of
I'm
you were going to
surprised
do
about
open.
this.
Well, so is anybody surprised by these results? Were you surprised by this, Katie, or is this what you thought?
It's what I would hope, but I'm a little
Right.
surprised.
Hoping.
Yeah.
Hoping.
That's awesome.
Anybody want to defend one way or the other?
It's less invasive. If we can do it percutaneously without a cut down on the neck, and it has good results, that's a great. I'm not. Again, I'm always. Will tell you, I'm a dinosaur. I was doing these open until this year. I was like, oh, I could do perk in a baby. I had never done that before. Perk in an older kid, but not a baby, and I was scared. But looks like most people do that now. And by the way, the wire that we had was the wrong wire. Remember that?
Oh, really?
I told you. The kid, remember the wire came out on
Yep.
the change?
Anybody feel strongly about VA? Sounds like, or open, I'm sorry. Strong about open instead of perc, just, I mean, that's just the way you learned it and you've not tried the percutaneous? Or is it that you feel like the open is clearly the better, safer way? All right.
Why, Dave, do you think open's better?
I don't think it's an IJ stick when you do it percutaneous if you're dilating really down into the chest. I'm okay with it if you want to do a percutaneous. I'm a wimp. I'm going to still do this open.
Okay, that's good. That was a good discussion.
All right, guys, so we've got another infant, but this time the kid's got a CDH. And we know from prenatal diagnostic that it's a bad CDH, and the kid is now not perfusing, and the decision has been made to go on ECMO. VV, VA, or transfer.
The other bit of information we pick up with this last questions is about 12, 13% of the group transfers are not doing this.
Well, there is a definite left ventricular dysfunction in most of these babies. You said there is a little bit of perfusion issues. So I would say VA, most of the prenatally diagnosed bad CDHs will need to go in a VA ECMO.
So I'll comment. I'm a VV answer to this one. So I trained at a very VA-heavy place, but our neonatologists swear that the oxygen that you get from VV is the most potent pressor that you can give. So VV, I mean, there's a chance you're going to have to convert to VA, but a number of these kids can be supported on VA or VV. But clearly, I'm in the minority.
I agree with you. I don't do ECMO anymore, but I've seen several kids, you start the VV and within minutes, before you even close to make a decision, you're starting to weaning off pressures, the left ventricular function improves and all that. So I think the default should be VV and add an arterial cannula if you have to, but not right away.
Yeah, I agree too. I think in this situation, VV is ideal if you can get it in. I think that's the first part, and I'm sure we'll get to that. But oxygen is probably the best inotrope you can have. So even if there's some limited cardiac dysfunction, provided it's not overt left heart failure that you need to offload the heart, VV actually gets you going. But this is, I'm sure you get to it, but this is probably one you want to do open and have the carotid ready in case you need to convert to VA.
Well, about 80% are not doing what you guys are saying, so that's maybe this is a moment. Yes.
Okay. Obviously, I mostly agree with Dr. Olatoye. I think if you're going to do open VV but plan to have the arterial cannula there, then I think the paradigm should be a primary VA strategy for these kids. You know, I don't think you try to get away with VV. Is you should plan when you have this non-specific question to say we should just do VA. Is kind of how I would approach these sick kids.
So once you're looking at the artery, it's hard not to cannulate it right then, right?
Kind of, yeah.
Others? Thank you. Good discussion.
All right, now you've got the adolescent. So a large adolescent has pure respiratory failure, VVVA, or transfer. I apologize for the guys that are transferring. We'll get through these ECMO ones quick.
Yeah, I had this case a couple of weeks ago.
All right, so definitive there. What is your preferred technique for this patient? Are you going to go percutaneous or open? Carly, please screenshot this one.
All right, we can go ahead, I think.
That's it. Yeah, big teenager who's viral. All right, well, Katie, look at that.
Yeah, I mean, that's definitive. There's probably one or two people that said open. If you want to speak up, go for it. But I'm surprised by this for sure. All right, so in that patient that we just talked about, so a large adolescent patient that we're going on VV ECMO, where do you guys do it? Are you guys going to the OR? Are you going to the cath lab? Does IR actually do this? Do you use echo at the bedside or some form of x-ray at the bedside? Or, yeah, so. So I think let's just start the discussion. So for you guys using echo at the bedside, I'm assuming we're all using a bicaval cannula. So you have to get into the inferior vena cava in order to place this. So you think that you can see the wire very reliably using echo, and you feel comfortable placing these large French cannulas under echo.
Caveat, I'm just a fellow, but yeah, no, I feel like in a longitudinal view and a sagittal view, you can get a pretty good view of the IVC and SVC. If you have a big, thick, 0-5 stiff amplats, you can get it across and follow it down pretty easy. And I'd want X-ray there too to confirm.
Thank you, Michael. Who else?
We always have the cardiologist that's there at the bedside that's helping us. So, and I've done that at 2 different institutions.
Anybody comment about the OR experience, getting the patient from the ICU to the OR and how that goes and back again? I know I'm always a little nervous about that. Back. Yes?
You can't see this wire as well with echo. I mean, especially in a 92 kilo kid. I think that's where imaging with X-ray helps for you to actually be able to find the wire and make sure in the IVC. Now, when you have the cannula in place, you can see your jet well on echo to make sure that you're having your jet go appropriately where you want it with flow. But looking for that wire with echo, I mean, that was the same problem with the perforations that were happening with the Avalon in infants, is trying to look for a material that's not really made echo bright, trying to find it with echo, especially in a big kid. Looking for that wire in echo is very dangerous. But in X-ray, you can see a wire go down just like we do central lines all the time. You can see the wire go down the IVC. You can follow it down with X-ray. It obviously means having an X-ray table or bringing an OR table to the ICU or wherever you're doing it to put the child on to do it with X-ray. But looking for a wire on echo is treacherous.
Thank you. Here's the.
Do you do ECPR? Quick one.
And then we should have a question that said, do you like it?
Do you like it? Not an ECMO center seemed to grow that time. It was 10%, now it's 20. ECPR, not an ECMO center.
Any comments about ECPR and just in general or educational for us? Any tricks of the trade?
Are you all in-house, the people that are doing ECPR? Yeah? No comments, Mac. Let's go on.
All right. All right. Todd, why don't you take this one, lead us through?
Oh. All right, 12-year-old male with a grade 5 liver injury that's hemodynamically stable and a crit of 37. Where do you send the patient? PICU, adult ICU if you don't have a PICU, transfer to the pediatric trauma center or floor. We didn't give home as an option.
Oh, wow. We've lost, I think, most of our trauma people. So we're going to the PICU with a hemodynamically stable grade 5 liver injury. Just because the radiologist told you it was grade 5?
This is amazing.
I mean, grade 5 sounds bad.
It
Katie.
sounds bad.
This is
The kid's sitting up talking to you.
so. At the end of Katie explaining everything, we're going to have people raise their hands if they would change their practice.
I'm not going to explain everything. Anybody from the trauma committee here?
I'm not on the trauma committee, but the last liver injured kid that we sent to the PICU had a grade 3 and was actively extravasating from that. So we're not looking at the numbers. We're not looking at the grade. We're looking at what the child's doing. Look at the vital signs.
Absolutely.
Yep.
So,
And the intent of this question is to try to play it, whether it's a 3, 4, or 5, play it as we've been staring at the kid long enough, the vital signs have been stable, and the crit's 37, so it's the way this one is being set up, I think.
I love this question for a few reasons. So, David, you always talk about we keep repeating the same things over and over again instead of saying, oh, we talked about that last year. We'll keep talking about it every year when there is a major practice-changing event. This, whether you believe it or not, that's a different story, is probably, in my opinion, in the last few years, one of the biggest radical shifts in how we did something. So the idea of not necessarily sending all grade 5s to the PICU and a few of the next questions are big practice changes.
We've got a comment over here, Todd.
What?
Yeah, over here, way over here. Hey. In this case, it doesn't honestly matter what I think, because getting the hospital to change to not admit to the PICU is way more of a fight to have them than just to have them admitted to the PICU for like 24 hours. And I'll argue not to get CBC, not to get an H&H, not to follow them, but they just do it anyway. And then when they realize that, oh, the patient's stable, they'll downgrade and send them to the floor. But I can't stop other people from admitting to the PICU. And I will get like probably a week's worth of emails and calls saying that I did the wrong thing if I insist that they go to the floor.
I love that you just said that. So that brings up a fixable problem. Who here agrees with Ronnie? Who Whoa. So you guys, all you people who are raising your hand are basically saying you would send to the floor, but your hospital would say no. That's incredible. That was like 30% of you. Is that a question or a comment? Or just no?
So if I send this kid to my floor, the hospitalists are going to freak out and demand they go to the PICU. Because the hospitalists follow everybody.
We
So
need to
it's not that
decide
the
who
PICU
takes
wants
care
them.
of trauma patients.
Yeah, but
Is it the PICU, the hospital, or the hospitalist, or us?
Yeah, you're the trauma surgeon. I mean,
Right.
yeah, but you got to look at the one who manages that injury. You're the one who does
We
it.
co-manage all of our patients on the floor.
Yeah, I mean, I went through the same grief for a year doing the APSA guidelines, and it took a long time to change that culture. Now, we have the advantage of staying in the house, but if we want to induce change and we believe those guidelines, we need to induce that change, not the hospitalist, not the ICU, not the ED. I agree with you, it's super painful. But in the last, 2 years, we haven't admitted a liver injury or spleen injury unless they're hemodynamically unstable or labile or getting transfusions. This is the only way we're going to induce change, is the people in this room.
I think you also have to consider your facility's ability to monitor that patient on the floor. Because, I mean, in our situation, nurses, we don't have the ability to really keep them on monitors on the floor. The nurses are overwhelmed. And now you've asked them to watch a patient very closely when they're already watching 3 or 4 of the kids. So each institution is going to be different. You just can't say this applies to everybody.
That's a good point.
All right, well, since this seems
I'd
clear
also like
cut.
to say that it depends on, all of our new nurses are starting on night shift. So you have fresh grads for 90% of our overnight nurses. So if this patient's being admitted at 10 p.m. at night with a grade 5 liver injury to the floor, I caution whether or not the nurse is going to catch the vital signs change in the middle of the night too.
Oh my.
Well, if you guys didn't like this question, you're not going to like the rest either. So, so how often do you check the crit? Every 6 times 2, no more lab draws, only if becoming unstable, other.
And while you guys are answering that, I just wanted to point out that a lot of people said, oh, worried about nursing staff on the floor, worried about hospitalists and PICU, but nobody said they're worried about their surgery residents. So that's really reassuring. So thank you, guys. Thank you.
All right, well, I think a point of this is maybe we can cut back on how often we used to draw blood on these kids is the point. So somebody want to defend no more lab draws, or?
Katie?
Yeah, I mean, it's actually interesting that more people aren't going to check labs than are going to admit to the floor. But Natrika, I'll speak on his behalf. Natrika was part of creating the consortium, the Atomic Consortium, and they recently wrote a paper that was published this year that says checking labs doesn't really help you. So that's kind of new, hot off the press, but I think these are all reasonable.
So basically, when we were creating these cases, it was basically Katie teaching Todd every single thing about pediatric surgery, because I didn't know this either.
Not pediatric surgery, Todd. There was a couple of trauma questions.
But this is like, I always thought you're supposed to get at least 2 crits. And Katie, you're saying if they're stable, in the ED, stable, you check 1 crit, you're done. You don't even check another crit.
Yeah, I mean, full disclosure, we're still doing A.
Oh, okay.
But this is this whole idea of implementation science, right? I mean, it takes a long time to make some of these changes, but I would love to move towards C.
Okay.
Any other discussion other than Todd and Katie arguing with each other?
Whenever they're good.
Todd, can I come back to the previous thing? I mean, it shouldn't be hospitals who decide what's best for the patient, right? I'm wondering if the APSA Trauma Committee could get together with the American College, and it seems to me if you have guidelines coming from those institutions that are evidence-based, then that should be the guide and not what the hospital
I agree with the second half of what you said. Trauma is multidisciplinary, so I do think you need to have everyone involved in the decision making. But the second part is, I believe APSA and other governing organizations should be helping. I don't think the hospital is stubborn. It's more that they probably need to bring about this discussion, and sometimes you need to discuss it 3 or 4 times before changes are made. But I think you do need buy-in from all the PICU, from anyone involved in trauma, but we should be more proactive about trying to bring about the change. I agree with you, sort of.
All right.
Can I make a comment
Yeah.
before we go on?
Please.
First, I think, trauma patients should be admitted to a surgical service. So the hospital should not be determining what happens to a trauma patient because they should be on the surgical service. So either on the pediatric surgical service or the trauma service or the orthopedic service or whatever, that's the first thing. Now, having said that, if the patient is admitted to a general surgery service where the one intern on call for the night is running around the whole hospital and doesn't get to see the patient all through the night, then is it really appropriate to say that you're going to wait until the patient is unstable to figure out what the next step is? And so that's why, again, it depends on each system to see how you manage what you do. Ideally, that patient should be on a floor on a surgical service where there's a surgery resident, PA, or whatever, monitoring that patient to determine if the patient is unstable and then at that time get the labs. But in the absence of a system where that can happen, you could see why many people would default to putting them in the ICU so you're safe in case for the rare occasion that the patient deteriorates. Or if you can't, put them on the floor, but then get the labs so that at least there's some other objective measure of somebody keeping an eye on that kid if the one resident you have who's covering the ED, covering the floor, covering everything else, actually doesn't get to see the patient. But ideally, the patient should be on the surgical service, monitored closely so that no labs are needed unless the patient is unstable. That's the ideal, and that's where we should go for.
All right. That sounds like definitive right there. All right. 8-year-old girl with abdominal pain for 12 hours, mild tenderness in the lower abdomen. White count is normal. At a slight left shift, ultrasound, imagine this, can't visualize the appendix. That would be a ultrasound read of 3. What would you recommend? CT scan, admit for OBS, just take out the appendix, send home with information about what to return for, or something else. I'm assuming that you guys have seen this situation before.
Sweet. This is what we were hoping you would answer.
All right, cutting down on CT scans. I guess we should have MRI in here now. Maybe that's the other. Is other MRI? There's some heads nodding, or other is something else?
I'm hearing other is MRI over on this side of the room.
So I think I'm hearing
hospital,
MRI,
and
right?
we can get an MRI round the clock, so we have a MRI
So
standard.
is getting the MRI just as easy for you as the CAT scan in terms of the ED and the hospital?
MRI is easier to get than an ultrasound, and is just as easy to get as a CAT scan.
What if it's a 2-year-old? You got to put him to sleep.
We do an ultrasound for a 2-year-old. Under 4, we do an ultrasound. Anything over 4 gets an MRI. 4-year-olds can hold still for the short MRI.
Mark?
Mark Downing. Ooh, sorry. Kalamazoo. So the real question behind this question is whether I can trust that it's really only been around for 12 hours. I took your 12 hours as written. At 12 hours, even with a CT scan or an MRI, I might have some confusion as to whether I have appendicitis or not. My preference would be to send this patient home and have him come back to my office tomorrow. And of course, families aren't always excited about that, so my second would be to admit for observation. I'm not ready to do more testing at this point.
Well, these are always Friday night at midnight, so.
Makes no difference. We operate 7 days a week.
I was thinking about your office.
So
All right,
part
the
of
same case, but she doesn't live nearby. She lives 3 or 4 hours away. And I think those of us who work at referral places, you know, this is not unusual to have somebody drive a long way in Utah to get to the big hospital, and then what? Do something different?
All right, good. I don't feel alone. Part of the reason we're doing this question is because I get you can always tell if I've been on call the night before because there's like 6 admit for observation abdominal pains. And I'm being taught now that I can get the courage to send these patients home.
Can I say something, Todd? Admit for observation, we never have beds available. You know, Canadian system, it's always full. One option that's very doable, if it's 10 o'clock at night, we keep an emerge overnight for observation. We reassess in the morning and then either send them home or bring them in for appendectomy. So it's kind of an in-between. There's much less stuff involved in admitting, you know, with the nursing admission, with the surgical bed admission and all that. You just keep them under observation and emerge.
So
and you realize that ED docs don't like that. And the nurses, you're filling up my ED. Would you get them out of here? Go to the OR.
I think the change that's being addressed here that a lot of people are bringing up lately, Ellen, you and your paper, a lot of people are talking about this, that if you look at the data of those who are admitted for OBS, they've had an equivocal imaging with a surgical resident or a surgical attending exam, the incidence, if you don't go to the OR, if you separate to went to the OR or not, almost all of them end up not having appendicitis. There's an incredibly small number of patients that don't go to the OR that end up later being declared as appendicitis, thus being suggested to me that you can feel safe sending them home, telling them to come back, that the incidence of a problem is in 0 or single digits. Yeah.
So we don't do a ton of CT scans, but we still would like to decrease our CT scan utilization. That being said, I keep selecting other because what we realistically do is actually talk with the family about the options. And we tell them we can admit and watch. We talk about the risk of a CT scan. And some families just want to get as close of an answer as they can and get out of there if they can, and if that's deemed safe. And it depends on other clinical circumstances that you haven't, gone into other details about other symptoms, but we talk to them about the options and let them participate in the decision.
Yeah, I was just going to say, sometimes there are logistical factors too that kind of influence what we do. So where I trained as a fellow, we always would admit these kids overnight for observation, but that's because we were at one single freestanding children's hospital. Where I work now, we're a health system that services 9 different facilities, but only 1 can admit pediatric patients. So when they present to those other 8 ERs, I'm more apt to do the MRI because I don't want to have to, if I want to observe them, I have to transfer them to our primary site, versus if they present to our primary site, I'm more apt to admit them for observation because they're already there and no transfers needed.
I had a quick comment to make. So, unfortunately, physical examination has become a dying art in North America. And we did a study comparing the rates of CT scan used for diagnosing appendicitis in the US versus Europe. And in the US, if any child presents to the ED with abdominal pain, 60% of them ended up with a CT scan, whereas in Europe, only 3% got a CT scan. In the past 2 years, I was in England, and not a single kid got a CT scan to diagnose appendicitis, and Nigel Hall can back me up on that. So again, it just reflects on the, what used to be a clinical acumen, but now everybody gets a CT scan.
So it sounds like we need to talk to the family and we need to examine the patient. Is that what I'm?
You just said a comment that, I know, Mac, we want to go, but the question was talk to the lawyers. Here's the question. For those of you who admit for observation, is part of that out of medical legal concern, or do you truly believe it's dangerous for that equivocal child to go home and call to come back? Is it that you believe it's dangerous for the child, or is it medical legal protection? Medical legal. Raise your hand if it's medical legal. Okay. Yeah.
I do a lot of work in a referral center, and I've had many calls from outside hospitals. Clearly the kid doesn't have appendicitis. Clearly the radiologist overread. And I always say, talk to the family, tell them it's a low chance. If he's having problems tomorrow, tell him to come back or come to see us. And I have yet to have an ER doctor from a referring hospital that will do that. Almost always they'd rather it become our issue, and that kids get sent up. More often than not, we see them in ER, and most of the time it's in 2 o'clock in the morning by then. So it's like, well, they can go home in the morning because there's no way they can get home because they got there by ambulance of all things. So.
I keep suggesting, putting other because this decision has been made already. By the time I hear about this kid, I also work at a place a freestanding children's hospital that supports like 13 now community hospitals, and by the time I hear about it, the ED's already gotten a CAT scan. So we almost never get to make this decision unless it's, Monday at 9 a.m., but it's never Monday at 9 a.m.
Well, there's a pediatric appendicitis score sheet that you could teach your ED to use, and if they have a certain level of a score, they're supposed to call you before the CAT scan. So that's published data. All right, we're going to keep going, though. This is a skinny 6-year-old is diagnosed with non-complicated appendicitis somehow. What is your preferred operative approach? Single incision laparoscopic appendectomy, and there are 2 ways to do that, or 3. 3 trocar, or anybody know how to do an open appendectomy? It looked like a race for the moment. All right, so nobody's doing open. How about a single site advocate other than me? Can somebody else stand up and talk about why you like single site? There's arms back there.
Can somebody explain why you're going to do a 3 trocar immediately before deciding what to do? I mean, that's the question. I mean, you're going to start with 3 trocar, whatever happens. So why?
So Miguel, are you saying you put in 1 first and look around and then make a decision, or just I always do 3 trocar appendectomies?
No, the question is you start with 3 trocars. So why? Just put the scope and evaluate the situation, and 90% of the cases you will be able to do it with 1 incision, that's all. So the question is, why starting with 3 trocars?
I see. So now we have examined the patient,
And
talk to the parents, and then the Chilean way, just stick 1 trocar in and look. Other comments? Ronnie, did you have something? There's a microphone right there. It depends. All right, so tell us how, if you do it both ways, how do you decide?
If you're comfortable doing it in a single incision, it doesn't take any longer and your outcomes are the same, why not?
It's better cosmesis, too.
Yeah.
All right,
Especially.
Other advocates for one way or the other? All right.
My experience is the parents don't care. I did this study myself, and the parents and the patients don't really care about the 2 little small stab incisions. So I started with a lot of interest in single incision, and I've kind of abandoned it because I don't think they care.
I tell you what.
But it's so fun.
In my experience,
it gives me joy to do a slappy.
They care post-op. They don't care right then when you're doing it. I'll switch to cholecystectomy. I have many, many, many pictures of teenage girls holding up their shirt post-op showing no scar, and mama holding up her shirt and showing the 3 bullet holes, and they care.
I haven't found that. I found it, honestly, I found them not really. We tried to blind them in our study, and they didn't really care when we took it
Maybe
off.
you're talking too much to the parents. All right. For those of you who did single site, there are 2 ways. You put in a port and you have multiple ports through that port, or you try to reach in and grab the appendix and yank it out the belly button and do an external appendectomy where you actually have to use things like vicryl ties and things like that. So which way do you choose if you're a single site person?
So for those who want to do 3-port, are you opposed to this concept? Okay, you're doing a 3-port. You put in your first port in the umbilicus, you look in, it's sitting right there. Just grab it and pull it out. Like what? It's not like you're doing anything different. You're putting the port in, if it's sitting right there, grab it, pull it out, and tie off the appendix. Rather than by the time you've done that, you could have put 2 more ports in. It's the same time. So why not do that? Why not grab it and pull it right out? I mean, I understand if you don't want to do an intracorporeal appendectomy because maybe that's a different skill set, but if you have your camera in, just grab it. Is there an opposition to that?
I think people are afraid of. I pull it out, but I think people are afraid of wound infections. So we pull it out. I do it. I don't even use a trocar. I just use a 2-in-1 and pull
I
the
think
thing
Kansas City dispelled that concern in their study where they showed there was no difference.
There's not, but I think if you ask around, I think that's probably why people are afraid of doing it that way.
Okay.
So the answer here about the single site where you reach in and just however you do it, grab it and pull it out, seems to be the majority. So 3 days ago before I came here, this was being done at my place, and the appendix was pretty bad, but thought we could pull it out through the belly button. But when you're trying to do that, all of a sudden it tears in two, and you've converted acute appendicitis into ruptured appendicitis. Anybody ever had that?
It's one of our questions, I think.
Next question.
That's one of our questions.
Sorry.
Yeah.
Keep going.
I was just reliving.
Yes, you perforated it, so now what are we going to call it? Are we calling it perfed appy, or are we calling it uncomplicated appy?
I selfishly looking to see what everyone does here because I'm undecided. So I'm going to go with what the audience says. Okay. So non-perfed appy, you grab it, pull it out, and on the way out, you get a hole, or then now you admit and treat with antibiotics. Is that what people are saying? I've always debated. Now I know. Any questions, comments? Yeah.
I think it depends on when and where this happens. If it happens when you're outside already, the appendix is out, you have a small tear in it, I would treat that as uncomplicated. If you tear it intra-abdominally as you're mobilizing it and there's pus everywhere or fecalith, that's a different story.
So you would not do it for fear of a wound, treat with antibiotics post-op to prevent a wound infection?
No.
Okay. Fair enough. Good. That helps me.
So source control was achieved. Stop at trial says this is not the data.
Okay.
What's the difference in pathology here? We just pulled it into two pieces, but it's not a perforation by definition based on pathology, right?
I call it the grip and rip, but okay.
So 73% of you disagreed with that. So who's got an argument, or is there just, it's no argument, it's just kind of what you do? Rod?
So we treat this as a third type. So we have uncomplicated, we have gangrenous or intraoperative spillage, and then we have complicated. In the complicated, we're trying to move toward a stop at trial, working on it, 4 or 5 days of antibiotics. The middle ground, this, if you just think of wound class, this isn't dirty. It's still contaminated as long as it's controlled spillage. And it's definitely, I agree with the previous speaker, it's completely different pathophysiology than the perforation that has soiled the entire abdomen, or even an abscess that has resulted in a very different pathophysiology.
So if I send my appies home from the recovery room, it rips on the way out, I can probably still do that.
So the way we treat it differently is uncomplicated, we're done with antibiotics, complicated 4 to 5, and then this middle ground of gangrenous or intraoperative spillage gets 1 day of antibiotics, which means they stay overnight for their next dose.
Fair enough. I like that. That's a good.
Yeah, we followed. We used to have 3 flavors of appendicitis too, and we established a pathway and a protocol, and we followed it for a couple of years, and we tried to pull out the gangrenous or suppurative or whatever that middle, whatever you want to term that middle flavor was, and we found that they behaved exactly like the uncomplicated. So we took them out of that third flavor, and we have gone to 2.
It's a great subject, though. Go ahead.
If the appendix looks normal on a slappy, do you put a couple more ports in and look around? Yes or no?
For the nose, is that because you feel like you can do an adequate expiration with what you've got? Ronnie's nodding up and down. Others? All right. Stay on the theme here. A 12-year-old with perforated appendicitis and an abscess, diagnosed by a good history and physical, a CT scan, an MRI, or an ultrasound, doesn't matter how you got there. What do you like to do? Appendicitis is appendicitis, let's operate. Drain, and we'll assume that's kind of IR guided. Just treat with antibiotics, and have that be all you're going to do, or antibiotics and plan for an interval appendectomy.
How long has a patient been perforated?
Question is, how long has the patient been having symptoms?
Let's just make up 5-6 days.
How big is the abscess?
We'll say 4.5 by 4.5. All right, we got two big groups, so there ought to be people willing to stand up and say why they think one's better than the other, please. John Waldhausen.
I thought this had been settled a long time ago, that to drain it was more expensive because you got to drain it, keep them in the hospital, and then bring them back to do an appendectomy. And if you just operate on them, you're saving money. You get them out of the hospital, they do it. This is an old paper.
And you're a chief of surgery somewhere who's in the money meetings all the time. All right, so that's one argument.
Yeah, I agree with that for the most part, but I think it depends to me. Like if I try to operate on these when they're if it's true abscess that's been out there for 7 days, you can get in there, it could be a disaster. I've been operating closer in the 2, 3, 4 day period to taking him to the operating room, getting it out, and then, if it is really a 7-day large abscess, I drain it and come back.
All right, well, over half of us said drain, so somebody needs to get up and tell us why that's a good thing. Come on now. I'll start calling on people. Chuck?
Did you call my name?
Yeah. We're way back there.
I think we studied it. I'm sure other people did too, and we kind of concluded what John said. I suspect our current management is pretty much to operate on them with some caveats, and the caveats are, it depends on what they look like. If they've been sick for 5 weeks and they've got a well-formed abscess and they don't look too bad, sometimes we might drain those kids and not operate on them right away. But if they're within a week or so, we usually would just go ahead and take them to the operating room.
Okay.
Come up here?
No, you take over.
Oh, let's do it. Okay. Which antibiotic? There's a few new papers out there, I think. What antibiotic are you giving these guys IV in the hospital? I think we can start making some of these appy ones quick.
What do you do, Todd?
So we've been using ceftriaxone and Flagyl, and now the single agent paper has been published, so I think we've been talking about that. But I think we're still using dual therapy.
Others, comments? Is part of a protocol, or is it individual surgeon judgment? How do you decide? Oh, infectious disease. All right.
Okay, perforated appendicitis. The kid is ready for discharge, looks good, not having fevers, eating, walking around the hospital. Are you going to send them home with antibiotics? Yes or no?
So just to clarify, so this is a patient that had perforated appendicitis, they were admitted, and now they're well enough to go home. So most of you would send that patient home on, continued antibiotics after discharge. Is that right?
Again, this is another 50-50 deal for us, so anybody feel strongly? Obviously, there's an effort for us all to use less antibiotics as much as we can, so this is part of that movement as opposed to the automatic 10, 14 days of antibiotics just because I decided that on the front end. We're supposed to be thinking differently. Oh, yes, please.
Mac, we just heard the results in this meeting, the first day. I mean, it's fresh. They don't make any difference. So if we hear those results and we're not willing to change practice, I don't know. There's not going to be much that changes practice.
Well, one of the purposes of this session is that we take what we hear sort of at the science level and then ask people what they're doing. So, other comments? All right, keep going, Katie.
How many days? Okay, so this kid comes back with a 6-centimeter abscess that's drained by IR. We've heard a little about the stop-it trial, but drained by IR, source control now, the abscess is gone. How many days of antibiotics?
And how do we pick 7?
Football score.
That's my theory. We do have some zeros in there. Anybody want to advocate for that? Canadians.
But sorry, I think it depends on clinical response, right? If the patient, you may drain one abscess, but they may have loculation, may not be well drained, and if he's still febrile after 5 days, you still need antibiotics.
JM and I have been worried about Sharif. He might be postprandial or febrile because he hasn't been talking about appendicitis.
I agree with John Martin. It depends. You follow the clinical response. If the child gets better, then they don't need any more antibiotics. But if it continues to spike fevers, then maybe you need to think more about A, source control, if you really drain the abscess, and B, further antibiotics, or different antibiotics.
Okay, we're going to rapid fire through a couple more real quick ones here. Kid is found to have incidental appendicolith on a workup for something else. Parents are very worried about what that means. Do you recommend appendectomy? All right, not a big surprise. Now, in my practice, here's what happens. I vote no, and they come back to my clinic every week still worried and still complaining about pain. And after 4 or 5 times, now what do you do?
But that's different than incidental. So if they come in with pain.
Well, what they're doing is they have some abdominal pain that may not be anywhere near the right lower quadrant, right? But the parents now know there's this ticking time bomb. All right. All right, moving on. You want to take this one too, please?
Todd, you want to do that one?
Todd, you want to do hernias? Yeah, Todd needs to do hernias.
Okay. So we have a 17-year-old, the dreaded 17-year-old hernia. 17-year-old male presents to clinic with an intermittent bulge in his right groin. It's uncomfortable but not painful. Do you do an open mesh repair, open high ligation, lap high ligation by whatever technique you want, tap or TEP? And by the way, from tap and TEP, that doesn't mean you do it. That could also mean you send them to an adult surgeon to do it. And then I'm curious, who here does tap or TEP? Wow. Who themselves does a tap or TEP? Anybody? See, I knew I was going to be the, like, because you're fresh, like, you've done it recently, right? Yeah. Yeah, see, I haven't done it in like 25 years or something.
So yeah, I have a partner who was in the Air Force. So he worked in the Air Force for 5 years before doing his PEDS fellowship. He does it all the time.
I see. So those who answer D and E, is it mostly that you would then see that patient say, uh-oh, you have a hernia, I'm going to send you to an adult colleague? Raise your hand if that's what you would do. Okay. Okay. Any other have a comment? Oh, a lot. Okay. Nigel first.
Me. I have.
Can I ask the people who do a lap high ligation in this age whether they think it's difficult? I do all my hernias lap in younger kids, and I've had a few older kids this age who have struggled to do it. A lap high ligation, just the ring's so huge, the muscles are big and can't get it closed easily. I also wonder about whether it's truly an indirect hernia and whether you've got the same pathology in this age, because I've had a few kids who are teenagers as well who have actually done lap and have turned out to have indirect hernias.
I think it's easiest in this age, actually. I think the bigger they are, the easier it is to do, but that's just my opinion. It's all spread out and whoosh, easy. The spinal needle.
I have a question. Why people said open instead of a laparoscopy if it's the same high ligation? Why doing open on purpose?
There's a difference between an open and a lap high ligation. One, you resect the sac, and one, you just tie it off. Who wants to argue for an open high ligation and why you would not do it lap versus you just don't know that technique, or are you opposed to the laparoscopic high ligation in a 17-year-old? Someone's got to have an opinion on this.
Yeah, we do. I do an open high ligation for several reasons, I guess. One is that the residents don't learn how to do open inguinal hernia repairs if nobody does them anymore. And then in this particular case, it's pretty easy to convert to a McVeigh type repair if you need to do that. In contrast to the stuff you've looked up in your data, at least in my limited experience, even in these older kids, it's like 99% of the time, it's still an indirect inguinal hernia, and it's not necessary to do that, although some of the data contradicts that, I guess.
You don't do open cholecystectomies for that same reason, do you?
No.
All right, a couple more.
John? I think this was a spaced learning question a couple of weeks ago where they asked the equivalency between mesh and high ligation, no matter how you do it. And it said that the two were essentially equivalent. And because of the long-term risk of vast fibrosis with a mesh repair, I don't know why you wouldn't just do a high ligation no matter how you want to do it.
All right, we'll go to the next case. Todd, keep going.
2-year-old male with an intermittent bulge in the right groin. Do you do an open high ligation or lap high ligation? So now it's not so hard of a question. It's just a 2-year-old. What do you do in your practice? Standard hernia. Wow. Oh.
I do think the laparoscopic people vote quicker.
Well, they're faster with their hands. Like, did you notice that?
They have
That was a great study.
Wow.
Okay. Any comments? All right. Let's keep going. Female, open or lap? Ooh, this will be interesting to see if it's the exact same numbers.
I bet it changes.
It's about the same. Is it a little more lap? People are afraid of that old vase. Okay. Comments? Okay.
One more.
So I had a question. So I didn't learn lap in fellowship. I'm trying to learn it. And I have real concerns about the learning curve. And like, when am I going to be safe to do laps? So I've do more opens than lap. And, you know, Bethany Slater is one of my partners. She's amazing. She's trying to teach me how to do it. I'm a slow learner. When is it safe for me to say, okay, I've overcome my learning curve and I'm safe to do it laparoscopically?
I'm not sure I'm the one to answer that. I'll just say that you're not the first person at this meeting. I think there's been like 4 people that have said that same thing. It's frustrating because it's like the easiest looking operation. It's like just put the stupid stitch around the circle, but it's painful sometimes, and I guess you just know when you know. I don't know. I would do it, and then it's good that you're with Bethany. That helps. But if you do it lap and it's not going well, then just open.
All right, thanks. Katie, can you take this last one for us?
Yeah, let's do it. All right, we got some trauma coming. So this is a 4-year-old female who presents as a high-level trauma, so high-level trauma activation after a high-speed motor vehicle crash. She's GCS of 8, so she's intubated with an obvious head trauma, but no other obvious injuries. What is your initial imaging for her cervical spine? So she's 4, CT, X-ray, MRI, or consult spine. So I'm curious, I know we're always trying to limit radiation, but this kid has a head injury. I'm curious how you guys that are getting the X-rays, how do you actually do that? Are you doing it in the trauma bay, just get the X-ray?
This is something I've really been passionate about, not doing CT scans of the C-spine because you're going to leave that kid in a collar and can work towards getting the plain films you need, and because we have data to demonstrate that we're going to create thyroid dysfunction and potentially, worse. I think we have the time and space. The kid's going to get admitted. We're going to do serial exams. You can have somebody stand at the end of the bed, pull shoulders, have somebody stabilize the head, get a lateral and an AP, and start with that and take it from there. But I think we can safely manage that patient without CTing the spine. And one of the ways to look at, you worry about C1, 2, like having that kind of hangman fracture, is just devise your CT protocol so that you see that on your head CT.
Thank you, Catherine. So that's from one of our ABSA trauma leaders. Other comments?
Yeah, I completely agree. And it's never an emergency, really, to get the x-rays of the C-spine. So half the time, this kid will wake up and you have a clinical exam. They don't have any pain or anything. And you've scanned a zillion patients that don't need to.
The kid's now GCS of 3 and has a bolt. All right.
You ready?
Same thing, you're keeping the collar on, so I wouldn't do anything different.
What about pressure ulcers with these collars just staying on? Okay, next question. How do you decide at your institution if you're going to screen for a BCVI? So a blunt cerebral vascular injury. I don't know. I use some kind of a scoring system. There are several out there. I don't think we have a clear understanding of which is the best. We screen all head injuries only if there's a seatbelt sign of the neck or ask neurosurgery.
True confessions, when Katie and Todd and I were going through these questions, Todd said, I don't know, and I said, ask neurosurgery. And Katie said, you're both wrong.
Question was, is there a spine fracture?
Yeah. So I think it depends. We have these scoring systems out there. They're great for adults, not really great for kids. And so I think I'm honestly between A and B because the data is not great for kids, and I think we're still working on that. But until we get more data and multi-center studies, I don't think we know the answer. So.
Adult trauma hospitals are starting to trend towards screening everyone because of missed injuries. So I think it's an interesting topic that's kind of hot out there right now, but I don't think we know. So now this kid, the 4-year-old, is in the ICU, and it's 10 days in the PICU, and she has a bolt. How do you manage her C-spine now? So continue in the C-collar until she gets an MRI, until you get a physical examination, or you just clear it based on you got a CT scan. Most people got a CT scan, so you just clear it based on that normal CT scan or a spine consultation. What are you guys doing 10 days after injury? I would love to hear from somebody that says C. Who takes the collar off based on a normal CT scan? Anyone? The adults are doing it.
I think we need to address it earlier than 10 days. So if you still have a collar on at 10 days, it needs to come off.
Wait, hold up. So this was where I got held up. This is where I said to Katie, this is a huge question because I did not know that. So you take it off because you're comfortable that there's not an injury, and you can really do that based on the original CT? Like, this is totally new to me, so this was practice changing.
No, don't change your practice like that, Todd. Not yet.
Right. What's that?
In the adult literature, they said if the CT scan, the study showed the CT scan is negative, you can take them out of the collar because the risk of ligamentous injury is so much less in an adult than a child. That's why we tend to take them out of the collar for the adults, but the kids get an MRI if they can't. And then the other question is going back to, the PCARN data, going back to the CT scan of the neck, the PCARN data says the kids have a GCS of 8 and so on, you should get a CT of the neck at the original evaluation anyway. So your CT is negative for a spine fracture and there's no other injuries or there's no other evidence of things, then you wait and get the MRI as soon as you can. That's how we manage it.
So again, who would take off the collar? Nobody. One person. Wow. Okay. All right. There you go.
That's it, guys.
Thanks, everybody.